This truly is a pleasure, especially to follow Dr. Koh's keynote lecture. And to kind of say, all right, given this elegant surgery, what does the literature say? How do we translate from what we are doing and what we're thinking about to ultimately how do patients do? And I'm really going to discuss it from a standpoint of endometriosis, and because we could go all day long in terms of discussing pelvic pain and treatments for pelvic pain. If you look at women with endometriosis and comparing them to women with normal pelvises, in a study that was done recently in fertility and sterility, Ballard found that indeed there are certain symptoms that go along with endometriosis: throbbing pain, gnawing pain, that dragging pain to the legs that unfortunately, I'm sure looking in this room, many of you have had to deal with. If you look at it from a standpoint of superficial and deep endometriosis, particularly if you talk about your insides being pulled down, that sharp rectal pain, that's the kind of pain that Ballard saw that was more likely to be deep endometriosis rather than superficial. You can see all these other different types of pains, whether it was superficial, deep, you really had no correlation at all. Falcone in 2002 did believe that indeed when you're looking at symptomatic deep infiltrating endometriosis, depending on where it was, what type of symptoms you had, was the type of pain that was noted. For example, if you had severe dysmenorrhea, severe painful menses, there was more likely to be adhesions behind the uterus, and it was associated with decreased pregnancy. Pain with intercourse, well, that was the ligaments right underneath the uterosacral ligaments was the spot for the deep infiltrative endometriosis. Or on the bladder, obviously, because both the bladder, rectum, uterosacral ligaments, all very close to the vagina. If you're looking at non-cyclic pain, this is more of a bowel type of problem. Dyschezia, painful bowel movements, is again increased with endometriosis of the vagina. Lower urinary symptoms reflect back to the bladder. GI symptoms, again, bowel and vagina. So he thought that you could isolate endometriosis, suggested that you could isolate where you anticipate endometriosis based indeed on symptom recognition and a careful, detailed physical and history. Well, back to Ballard, and this was a later article, nearly a decade later, she found that indeed there was indeed no correlation between the site of the pain and the type of pain that was, or site of the lesion and the type of pain that was demonstrated. None of these p-values showed anywhere close to significance, whether you were dealing with right or left-sided pain, low back pain, et cetera, et cetera, et cetera. This is a study, a lot of the literature that we look at on endometriosis, as well as fibroids for that matter, comes from the Italians. The Italians have done an excellent job in terms of really having very, very inquisitive minds at looking at literature. And this is a study that was done by Gruppo Italiano, their endoscopy group, and this was a multi-center but was an observational study. And for those of you who are not as into research, it's always nice to have that comparative study where you have a control group, et cetera. But this was an observational study, so not perfect. But nevertheless, there was felt to be no clear-cut association between the stage, site, or characteristics of endometriosis and the pelvic pain. A study that was done by Sue, a later study looking at 133 patients, both with endometriosis and pelvic pain without endometriosis, Sue found that indeed women with endometriosis had, for the most part, lower mass indexes, were most likely Caucasian, had more previous surgeries, more frequent dysmenorrhea, and indeed incapacitation with that severe menses. Dysuria, painful urination, was most likely associated with endometriosis of the bladder, but that really was the only correlation. Ovarian endometriomas didn't correlate to pain site, nor did deep endometriosis, etc. The depth, the burden, the lesions, all did not correlate. Weir, in 2005, looked at nearly 8,000 patients. So certainly a large number of patients. And these were patients who were treated either for minor or intermediate conservative surgery for endometriosis. And as you can see, nearly 1 in 4 ended up with additional surgery, with hysterectomy being the conclusion in 1 in 8. This is a list, a compendium of a number of studies by some of the leading investigators in the world. And one of the things that you can see, whether you look at reoperation rate or pain recurrence, what you see here is nearly 1 in 4 patients will either note recurrence or will have a reoperation. Those are staggering numbers when you look at the number of patients worldwide being treated for endometriosis. If you look at the effect of surgery stage 1 to 4, these are non-comparative studies, so again, they lack that control group, but in Vignali's study, 24% recurrence, and the recurrences were greatest when you were dealing with cul-de-sac obliteration. That group of deep endometriosis that Dr. Koh talked about and you saw stripping out the rectum, etc. That these are particularly the hard group to get at. Now, are these really recurrences or are they just undertreated? That's something for us all to ask. Paolo Vercellini, 24% recurrence at 3 years. And look at, ladies and gentlemen, it really didn't matter what stage the disease was at. There was recurrence in stage 1 as well as recurrence at stage 4. The only covariate that was thought to be different was the fact that younger women had greater incidence of recurrence. A study by Shakiba, relative risk of surgery. As you can see, relative risk, the number is greater if there's a greater risk, and you see age 19 to 28, much greater relative risk of potential need for surgery. And if you look at pain-free, you can see that by 5 years, look at the difference. Only 1 in 3 are pain-free at 19 to 29, whereas at 30 to 39, it's nearly 60%. And over 40, it's greater. Why is that? Is Dr. Koh correct when he says perhaps we're missing something else in our diagnosis? Perhaps it's endometriosis plus, something that Dr. Chung has talked about, Maurice has talked about in terms of looking at interstitial cystitis as well. there are 3 controls. So despite all this literature on endometriosis and all the surgery that we do, there is very few studies that are randomized, controlled studies. One of these has been with Chris Sutton, who I was fortunate in when I was president of the AAGL, or scientific chairman of the AAGL, I honored him as our honorary chairman. And it was on the basis of his work with endometriosis I felt compelled to do so. He had the very first randomized controlled study on endometriosis. Jason Abbott from Australia and Gerald as well. If you look back at Chris Sutton's data, it's a double-blind study looking at women with minimal to moderate endometriosis. Now, what's confounding in this study is you see he treated this laser vaporization of endometriosis, but he also used uterosacral nerve ablation. So besides dealing directly with the endometriosis, he transected the uterosacral nerve, thinking that that also could give pain relief. And indeed, he did show that there was an advantage at 6 months in the laser group. But here's what's interesting. Nearly 1 in 4 of the expectant group became pregnant, were comfortable as well. He didn't do anything with that group. Placebo. Okay? Another confounder in terms of looking at data on pelvic pain. Again, Chris followed this up and showed that the laser group did better, but the expectant group did better as well. Jason Abbott looked again at an excision group and expectant group as well. So he had a randomized controlled study. What is interesting in this group is that the symptoms in his group markedly improved with excision versus the expectant group, no real gain in terms of pain control. And then he went back and excised the rest of the disease at a second look. What is interesting from Jason's study is that doing it a second time, it didn't do as well in terms of symptom treatment. Saying that first, in these days, I'll be politically correct, first woman in, first surgeon in, has the best opportunity to deal with the disease. Now, this is a study that was done by Gerald with mild to moderate endometriosis, severe symptoms, again comparing excision to observation, and that indeed there was really no difference in the pain at 3, 6, and 12 months. And when they looked at the dropouts along the way, again, there was no real difference. Was this the fact that we were missing other disease factors that weren't taken into account? In terms of long-term follow-up, this is kind of interesting. The group that ended up having to have surgery, now it wasn't significant, the p-value wasn't there, but even more people in the excision group ended up having treatment, at least as many. So long-term, what is the real effect of this baseline surgery? What does the literature really show us? Well, this is a study that was done by Wright. We talk about excision, we talk about ablation. And if I went all around to you, if I went to all of you today, because you are a very smart group on endometriosis, and I said to you, is endometriosis excision for pelvic pain better than desiccation? I'm sure every one of you would say excision's better, but I'm going to ask you the literature, okay? And indeed, there was somewhat of a difference in pain score. There was a trend toward, and trend towards are important, but it wasn't significant. If you look at ovarian endometrioma, so when I come to you with excision of disease, with mild to moderate disease, I cannot tell you that there is a distinct advantage to treatment. I can tell you that a significant number of women ultimately who are treated will, by necessity of their symptoms, be treated again. And I herald what Charles said. Absolutely, it is imperative that we look at other options in terms of diagnoses and treatments. Well, if one looks at excision versus desiccation of the endometriomas, one will see that indeed excision is better from a standpoint of rate of occurrence, recurrence, reoperation, dysmenorrhea, dyspareunia, non-menstrual pelvic pain. So across the board, excision of endometriomas appears to be better. I'll cite two studies. One was in fertility and sterility by Beretta in 1998, randomized controlled studies, just what we like. And indeed, if you look at recurrence of symptoms, you had a doubling of the time to recurrence in the excision group, 19 versus 9.5 months. Alborzi's 2007 study, a later study, again, randomized controlled, excision versus desiccation. There was definitely greater recurrence at 2 years in the coagulation group. So I think one of the messages that clearly is, if you're going to have an endometrioma removed, the patient should know it should be excised and not desiccated. But, and we just had an article out about this in our Journal of Minimally Invasive Gynecology, the AAGL's journal. It's important that you remember, and back to what Dr. Koh says, it's like we're twin sons with different mothers here. Back to what Dr. Koh says, it's important that you find the right surgeon, because what we showed in our article, the fact that you can injure the ovary if you do not meticulously dissect out that endometrioma and minimize energy in the process, that can have a real negative effect on subsequent pregnancy. And there's wide literature to support that. Well, what about, remember I talked about uterosacral ligament transecting the nerves. In literature, there does not seem to be any reason to support that. There is some work to show that if you dissect out the nerves over the sacral promontory, the superior hypogastric nerve bundle, that indeed you can have some advantage to that in terms of pain relief. This was a study by our friend Fulvio Zullo, who looked at laparoscopic presacral neurectomy versus conservative surgery alone, and his pain relief both at 6 and 12 months were better when presacral neurectomy was performed. I want to spend the end of my talk on a subject that, again, Dr. Koh showed us some beautiful examples of: deep infiltrative disease. Now, Versalini feels that indeed endometriosis infiltrating the vagina and anterior rectal walls can be symptomatic, and particular types of symptoms such as pain with intercourse, pain with bowel movements, pain with menses. Rectovaginal endometriosis has limited tendency to progress. About 1 in 6 patients will have deep endometriosis in the pouch of Douglas, so in the cul-de-sac behind the uterus. And around 10% with endometriosis will have deep endometriosis of the bowel, mainly rectal involvement. But this is a study done by Charles Chaperon from France, and indeed you can see 2 out of 3 patients, rectosigmoid or rectum involvement. But yes, we do see endometriosis of the cecum. We do see endometriosis of small bowel. We do see endometriosis of the appendix. One has to be cognizant of other areas and listen to our patients and really look at the time of our laparoscopies. Now, this is a little thing that I do. It's called OBGYN News. It's a throwaway journal for physicians, but it's a kind of relatively important because it's actually the most widely read article in gynecology. We have an ongoing article called The Master's Class in Surgery that I edit. And this was our first international author, Maurizio Abrao, who's an excellent, excellent laparoscopic endometriosis surgeon. And we talked about current diagnosis and treatment. And Maurizio talked about imaging, transvaginal ultrasonography, MRI, urography, MRI, and rectal endoscopy. Ultimately, I believe that vaginal, transvaginal ultrasound is a very good way of detecting the disease, and we use that along with colonoscopy. But here we are between a rock and a hard place. Incomplete resection negatively impacts success. We've already heard from Dr. Coe. Radical interventions increase risk. Where are we at? Well, this is a comment done by Vercellini when we looked at over 30 publications on endometriosis. And he talked about the fact that we don't have randomized controlled studies. The studies oftentimes are very small. They're single surgeons, so they're not they're not a multi-center study. So you get the effect, you get the thought process of a single surgeon. There are different types of techniques that are utilized. Some people resect. Some people just remove a portion. Some people do a bowel resection. So there's different types of techniques involved. Follow-up is short. Dropouts are not included. Oftentimes, physicians are not willing to share their bad results. Physicians have egos too. So all that negatively impact the data that you can get. The same thing was seen with DeSico in his look at this. All of them saying there's concerns about bringing in data. This was a study that was done, however, by Vercellini in 2006, who indeed showed that if one goes ahead and excises this deep infiltrative endometriosis, that whether it be painful menses, pain with intercourse, or painful bowel movement, there is a definite advantage of doing so. Muehlman looked at 49 different studies, nearly 4,000 patients, different types of surgery, bowel resections, partial resection with discs, or simply shaving. And what he saw in those studies was if you did not do a bowel resection and then went back and someone did a bowel resection subsequently, that 40% of those patients who previously had a partial resection now showed endometriosis within the bowel. The recurrence rate was greater in the patients who were treated conservatively, not with bowel resection. However, this is a study done by Roman, where looked at colorectal resection, bowel resection, versus nodule excision. And really, ladies and gentlemen, there was no difference between the two groups in his hands. We do know that there is oftentimes excellent short-term relief, but over time, things do get worse. And think about then that woman at age 24 who's getting a bowel resection. Where does she go? What impact does this have on future fertility? We also know there's the risk of post-op bowel complications, such as urinary retention, that neurogenic bladder, as well as fistulas. At least one thing we know, and this is excellent, this was a study that was done by Durai, that complications with bowel resections can be decreased with a laparoscopic approach. Again, something that Charles talked about earlier today. We also know that quality of life can certainly be improved. This was a study looking at segmental resection of the rectosigmoid with laparoscopy and was designed to look at quality of life. There was significant improvement in all pain-related symptoms, physical as well as mental health. And you can see, just going down the different types of pains that we've talked about, as well as even vitality, general health, et cetera, that patients following the resection did better. This was then a study that was done by Mobic, looking at both resection as well as shaving. Same type of questionnaire, pre and post-operatively. And in this group, both groups did very, very well, whether you shaved, you removed the nodule, or you did the bowel resection. Quality of life can be improved. So I leave you with this quote from Dr. Roman in Human Reproduction from this past year. The choice of the best surgical approach in the management of deep infiltrative endometriosis of the rectum is the subject of a debate that is far from over. We know this quote very, very well. Yes, we can do it. I ask you, should we? Thank you for your attention.